start umur kita. Al-Fatihah. Is everyone here already? I think. Okay, recording about to start. Still setting up. Okay, inshallah. So tonight, session is a PBL, problem-based learning, on postmenopausal bleeding. And so we will invite the speakers to present their screen, if you can. Do you have your PowerPoint ready?
Okay, so I will be presenting first. Can everybody see my slides?
Yes.
Okay, are they full?
Yep.
All right, okay. So today, me and my colleagues will be talking about postmenopausal bleeding. So first, we have to know what is postmenopausal bleeding. So it's any vaginal bleeding that occurs 12 months or more after the last menstrual period, which means 12 months means the woman has already achieved menopause. So it's a common problem. It occurs in about 10% of women that are over 55 years of age. A majority of them, which means about 90% of these women who are presenting, have a benign cause. There's no evidence of association of pattern of bleeding with malignancy. For example, if it's a one-time bleed or if it's a regular bleed, we cannot predict if it is malignancy or not because there is no associated pattern. So the main aim in primary care is to identify the cause and to exclude cancer because keep in mind, these are women who are postmenopausal, which is most likely over 50 years of age. So we have to start with getting detailed history and identifying risk factors. So before we start with our scenario for today, this is just some background knowledge, just so you may be able to keep up if you have not read on the topic yet. So these are causes of postmenopausal bleeding. The most common is actually atrophic vaginitis or endometriitis. The second most common would be exogenous estrogen, for example, those who are taking hormone replacement therapy. Then we can go into endometrial or cervical polyps or endometrial hyperplasia, as well as cancer. And then there's others such as vaginal trauma, sarcomas, or cervical cancer. The other table is just them listed based on their location, like endometrial, cervical, vaginal, or ovarian cancer. So we'll focus on atrophic vaginitis first because it's usually the most common cause of postmenopausal bleeding. It occurs around 10 years after menopause because of the woman gets older, she's obviously. So there's usually a decrease in estrogen that makes an alkaline pH of the vagina. So it's hygiene and history of oophorectomy can also be associated risk factors. It usually presents with scanty discharge. There can be pruritus, erythema, and sometimes there's burning pain or mild bleeding. There can also be dysuria or dyspareunia, and there can present with a decreased libido. If you're sending a message, I cannot read it. So we can also have endometrial CA or hyperplasia that usually occurs in nulliparous women who are obese, who have had late menopause or early menarche because of prolonged estrogen exposure. They can also have diabetes as a risk factor, use of hormonal replacement therapies, family history of cancer, such as breast cancer or ovarian cancer. And for endometrial CA, it's important to note that 10% of women who present with postmenopausal bleeding will have endometrial CA. So if you have 10 ladies presenting with postmenopausal bleeding, only one of them will have endometrial CA. However, 90% of women who have endometrial cancer will present with postmenopausal bleeding. Does everybody understand that? No interruptions, so I'm assuming that's a yes. So endometrial, we can also consider endometrial and cervical polyps. These are usually associated with risk factors such as obesity, late menopause, tamoxifen use, and other hormonal replacement therapies. Cervical cancer risk factors include multiple sex partners, early sexual intercourse, where the female is less than 16 years old, use of OCPs for more than 10 years, early pregnancy where she's less than 17, parity of 7 or more, if she's smoking or associated with a low socioeconomic status. Ovarian CA, also nulliparous, low parity, subfertility, early menarche, late menopause as well, ovulation induction, therapy, and family history of ovarian CA, because it's important to note that in ovarian CA, OCP has a reduced risk. So starting with our scenario, Madam Habiba, a 63-year-old postmenopausal lady, since 11 years ago, went for Hajj in Saudi Arabia with the Tabang Haji group from Malaysia. While in Mina, she noticed some pervaginal bleeding, which soaked her garments. She claimed that she had regular pap smear in the past and has always, the result of the pap smear has always been normal. Her latest pap smear was in 2019. She went to see you at the medical relief station. So what other medical history would we like to elicit? We have to go point by point. So initially, she presented with bleeding, right? So in the bleeding, we have to get full history of the bleeding, duration and severity, which includes the amount, if this is her first episode or if there's previous episodes, the nature of the bleeding, if it's fresh blood or clot of blood, and the source of the bleeding, because sometimes it can be confused for if it's parectal bleeding or if it's bleeding from her urethra instead of her vagina. So we have to know the source of the bleeding quite well, which means like you can ask her, is it happening while she's passing urine? Does she know where the blood is coming from? Is it happening while she's passing BO or bowel motion?
Sorry, Dua. I cannot hear you. I cannot hear your voice.
Do you want me to speak louder?
It's better now.
Okay.
There's interaction before.
I think I was blocking the mic. So we have to ask for associated symptoms, such as anemic symptoms, because she did present with bleeding. If there's any postcoital bleeding, if she presents with any dyspareunia, discharge, pruritus, or pain, because these are all linked to the table that I discussed above. If she is under any hormonal treatment, we have to know about the duration of the treatment, the type of the treatment, and the indication of the treatment. Usually, we give hormone to postmenopausal ladies for relief of postmenopausal symptoms. So we just have to know what it is and how long has she been taking it and why she's taking it, if there's any other indications, basically. We have to know if there's any constitutional symptoms such as loss of weight, appetite, if she feels fatigue, if there's any dyspnea, if there's pain, if there's fever of unknown origins, and etc. After constitutional symptoms, we have to ask about metastatic symptoms such as shortness of breath, any back pain, if there's any yellowish discoloration of her sclera, of her skin, or of her urine, if it's like darker, that she noted. We also have to ask if she has ever noticed if she has an abdominal mass or abdominal distension like bulking. If she has, then we have to ask about mass effects, such as which are compression symptoms, such as urinary frequency, if she presents with any constipation, if there is obvious abdominal distension, or if she has early satiety. Other histories that we need to include also her menstrual history, the age of her menarche, because we already have the age of her menopause. She's 63 and she's been postmenopausal for 11 years. So she achieved menopause at around 52 years of age, which is appropriate. It's not really a late menopause. We have to know her postmenopausal symptoms. We have to know her pap smear and the results of the pap smear, which was, the latest was in 2019 and it was normal. We also have to know her past obstetric history, particularly her parity, how many children she had, basically, because it can be present as a risk factor in the table that we mentioned above. We also have to know her past medical and surgical history. If she has any history of cancer, such as breast, ovarian, and colon CA. If she has any comorbidities that may present as risk factors, such as diabetes, any coagulopathies, or any radiation or chemotherapy that has been done in the past. Or if she has any history of oophorectomy. We also have to know any medication that she's on, such as if she's on use of warfarin or tamoxifen or any traditional medication. We also have to know her family history because of Lynch syndrome. So if she has any family history of colorectal, ovarian, or endometrial or breast cancer in the family, because in Lynch syndrome, it's an autosomal dominant method of inheritance. So it can give high risk of inheriting endometrial cancer. We also have to know her social history, such as smoking, any high-risk behavior, or any multiple sexual partners. So far, any questions?
No.
No? Okay, so then I will move on to her physical examinations. So she came to us in the care unit, and we have to do first general examination. So we have to know if she's cachexic or obese. We have to assess her hydration status, and we have to elicit for any anemic signs such as pallor, angular stomatitis, chylomicronemia, malaise, or lethargy. If there is any jaundice that may suggest liver metastasis, if there are signs of insulin resistance such as acanthosis nigricans or any fungal infections, if she has if we have to elicit if she has bleeding tendencies, such as if she has bruises all over her body that are not explained, or if there's any lymphadenopathy. We also have to assess her pain score at the time. Remember to take her vital signs, such as her temperature, her heart rate, her respiratory rate, and her SpO2, as well as her BMI. So moving on, we have to also assess for abdominal examinations. Abdominal exam, which is inspection, palpation, and percussion. If there is any distension or scars, we have to ask what the scars are for in the history of surgical history. We have to elicit for any tenderness, any mass, or any hepatomegaly if there is metastasis, or any mass in the liver that you can feel. We also have to do percussion for ascites, which may indicate ovarian CA. Moving on to her pelvic exam, we have to examine her vagina by inspection to see if it's dry, shiny, small, with a small opening, meaning, or if it seems very flimsy, very thin. We also have to do bimanual examination. Because we have to if we do feel a mass in abdominal examination, we have to do that to identify the origin of the mass, if it's a uterine mass or if it's an ovarian mass. We also have to do bimanual examination to assess for the uterus size, bulk, and position of the uterus, because we assume that in postmenopausal ladies, the uterus will not be so bulky. So if it is, it might give us an indication as to where the postmenopausal bleeding is coming from. So in speculum examinations, we also have to look for the shape of the cervix, if there's any indication of cervical malignancy, and we have to also visualize if there's any polyps on the cervix. We also have to visualize if there's any growth on the vagina, and we have to visualize if there is vaginal discharge. To complete our examination, we also have to assess with other examinations such as thyroid examination, breast examination to assess for breast carcinoma, and lung examination just to check for pleural effusion as a sign of metastasis.
Okay, hold on.
Yeah.
Let's stop there for a while. Dua, based on your history and examination, let's say the history was unremarkable and the examination were also unremarkable. Okay, so you can't find any particular cause that is obvious in the history or examination. What do you think is the provisional diagnosis at the moment before you embark on investigation?
So my provisional diagnosis would be atrophic vaginitis because it's the most common, and my history is non-significant, and my examination would not have revealed any mass or any polyps. So that would be my provisional.
Would what I'm trying to get, yes, you're right. Atrophic vaginitis is the most common. However, on examination, what would you expect when you do a pelvic examination if it's atrophic vaginitis? Because in this slide here, you mentioned everything. I want you to try to emphasize which one is more towards atrophic vaginitis.
Okay, so for atrophic vaginitis, during a pelvic exam, I would expect there to be scanty or no discharge at all. There might be some erythema or some pruritus, like signs of scratch marks. There might be also the vagina might seem shiny. It might seem smaller, with a smaller opening, and the skin would feel or look thin and flimsy, according to the pictures that I saw, but I've never seen it in real life.
Okay, yeah, you're right. I think the vaginal part of your slide there is all true for atrophic vaginitis. And what about pubic hair? You haven't mentioned pubic hair. What do you
Oh,
think the pubic hair distribution
scanty.
would be? Scanty,
Yeah.
minimal,
Yeah.
and yeah, yes, you're right.
Well, I will add that to my slides.
Let's say when you examine her, let's say it looks like younger women. It looks like reproductive age women. Okay, with a good it doesn't look dry, it doesn't look shiny, it looks normal size and not thin. Okay, what do you suspect if that's what you see during examination?
I would suspect cancer or polyps in that case. Given is the history still unremarkable, like she's not on any hormone replacement or tamoxifen?
Yes, that's right. If she's not on any exogenous, extra hormone treatment, and you suspect something wrong, then and what could be the source of this extra hormone if she's not taking anything from outside?
If she's obese, the source of the hormone could be from her fat conversion, the peripheral conversion.
Any other possibility?
No, not that I can think of. If she's not.
Any teammates want to help? So it looks like some hormonal changes, not from her taking any hormonal treatment outside. It could be because of obese, adipose tissue conversion, peripheral aromatization.
Yeah.
What else Could it be?
Could it be due to the estrogen secreting ovarian tumor?
Yes,
Oh.
that's right. Do you know a particular type that produce estrogen?
Granulosa.
Yes, exactly. Well done. Okay, so granulosa cell tumor can produce estrogen, which you do not expect um, after 11 years of menopause. So, uh, well estrogenized genitalia, and then when you examine when you do a scan, you would expect thickened endometrium because of the estrogen effect and so on. Okay, let's continue on to the next question on investigation.
Okay. So my colleague will be presenting her own slide.
Assalamualaikum. Can you hear me? Uh, can you see my slides? Hmm. Okay. Okay. So moving on to the next question. You advise her to see a gynecologist when she returns to Malaysia. So what further investigation will the gynecologist perform? So in postmenopausal bleeding, we must investigate further in order firstly to rule out the gynecological malignancy lah. So we have several investigation. We can divide it into bedside, blood, biopsy, which is the diagnostic investigation, and also imaging. So for bedside investigation, it is for initial assessment. So we can do ultrasound, whether transabdominal or transvaginal ultrasound. But transvaginal ultrasound is more sensitive than the transabdominal, and it is the investigation of choice to assess firstly to assess the uterine size and shape, and also the ovary, because in is my slide moving? Not moving.
No.
No. Okay. Macam mana?
Can you make it presentation mode?
I already make it presentation. Besar tak?
Tak nampak besar.
Macam mana?
Stop presenting balik, okay?
Sekejap Okay. Try balik Okay. Stop. Ada tak? Macam mana?
I can present. Nak aku presentkan lain?
I cannot present. I cannot click.
Aku let me present. Okay.
Macam mana?
Okay, tak dengar.
Kita orang boleh presentkan kalau
Present lah. Nani boleh present?
nampak ke?
Nampak. Okay. Okay, next slide. Okay, so for ultrasound, that I said before, transvaginal ultrasound is more sensitive rather than transabdominal, because it can we can see the uterine size and shape, and also the ovary, because in hyperplasia the uterine size can be increased. And then we can also see the endometrial thickness, in which if the thickness is less than 4 millimeters, it is unlikely CA because it is normal. But if the thickness is more than 4 millimeters, we might require further evaluation in order to rule out any endometrial CA. So we can also see structural abnormalities and also uterine margin irregularity, because in endometrial CA we can see if there is any hyperechoic endometrial with irregular margin, and also we can see if there is any uterus or adnexal mass, and then we can further evaluate the size, the number of the mass, whether it is solid or cystic, and if it is hyper or hypoechoic. And then we can also see any presence of free fluid, if there is any ascites present, and also we can see if there is metastasis to the adjacent organs such as the ovaries.
Okay, hold on. Back to the slide. Why do you choose transvaginal rather than transabdominal scan?
Because it is more sensitive than transabdominal, as we can further evaluate the uh, endometrial thickness clearly than the
Why do
transabdominal.
you see it's clearer compared to transabdominal? Why?
Why?
Any idea? A bit more specifics to the point answer.
Mm, can
Because
anyone
there's
help?
no overlying adipose tissue. In transabdomen, you have adipose tissue, so it could obstruct, and especially in morbidly obese patient, so it's going to be very difficult compared to transvaginal.
That's right. On transvaginal, the probe is very close to the uterus itself. It is very clear compared to transabdominal because of the layer of tissue. And the other thing is transabdominal, you need a full bladder, which sometimes is not ideal. I mean, it's not conducive for the patient, and so transvaginal will be better clarity of the image and everything. Okay, continue.
Okay, thank you, Jazli. So next for bedside investigation, we can also do cervical smear. As we all know in Malaysia that all women who are or who have been sexually active with age between 20 to 65 old, we advise them to do cervical smear annually. So if the first two results of the smear are negative, then we recommend them to do screening for every 3 years. Okay.
Do you know the latest one? That's true. That's the cervical screening program for Malaysia. But there's a latest one where
If
you incorporate another test. Any idea?
liquid bicycle.
Okay, the liquid-based cytology. Where you can add another test on it. Do you know?
HPV,
Oh.
serum HPV.
Serum HPV.
Can you elaborate what HPV can do? Any extra information about HPV?
I think
Yes, Azri.
I think like for the HPV, we would like to see any strains, especially HPV strain 16, 18, 31, and 33, because it have a high relation to the cervical cancer, unlike the other strains. So it is important for us to know whether the HPV, the result for the HPV lah.
Okay, that's true. 16 and 18 are the most common one, encompass about 80 to 85% of cervical cancer. And the next one, 31, 33. Yep, you're right. And the rest, 51, 53 are quite uncommon. That's one part of it. So you want to identify if she is high risk HPV or not. And another point about the cervical smear, if she has HPV negative, what will change in her management?
We repeat 5 years later.
Yes, well done. That's true. But 5 years later, she's already 68, so she doesn't have to do it anymore. And okay, unlikely. All right, continue.
Okay. Okay, so next for blood investigation, we can do blood investigation in order to assess the severity of the current illness, and also can do as a pre-treatment or pre-operative measurement. Okay, so firstly, because patient presented with PV bleeding, right? So we might need to check for her hemoglobin count if to see if there is any sign of anemia, and also we need to see her platelet counts in if she has any thrombocytopenia. We need to do also her coagulation profile in order to rule out any underlying coagulopathy, and liver function test to see if there is sign of metastasis or any other liver abnormalities, and then we also do renal profile to assess her kidney function. Firstly, because to before starting her treatment, and also as pre-operative measurement as well. And then we should also do random blood sugar because she is 68. She might have other comorbidities such as diabetes mellitus, which is one of the risk factors for endometrial CA. And then lastly, we can do also tumor marker. But tumor marker, we have so many tumor markers, but it is not very specific to endometrial CA, as it may rise from other sources, but it may rise if she has any ovarian CA, endometrial CA, and another CA. So next, so for in this one, risk malignancy index, we use it actually for risk stratification for ovarian lesion. So if we suspect this patient to have ovarian CA, so we might calculate her RMI. So in RMI, we have menopausal status, ultrasound features, and also CA1 to 5 level. So from these features, we can further evaluate her risk of getting malignancy from the table shows. Okay, next. Okay, next on the line we have biopsy, which is the diagnostic investigation. Okay, so first of all we have Pipelle biopsy. It is a very commonly used as outpatient procedure, so it's a very convenient for the patient as it also doesn't need anesthesia, but it is a blind procedure, so it might miss endometrial polyps, but it is highly sensitive to diagnose carcinoma. But it cannot be done if the patient has ongoing bleeding. Okay, next.
Hold on. Go back to Pipelle. Okay. Yes, you're right. It's the disadvantage is it's a blind procedure, and you may miss endometrial polyp, and more importantly, you might miss a focal lesion. Okay. There could be focal endometrial CA. Any idea where would focal endometrial CA most likely to reside? Most common location for focal endometrial cancer. Any idea?
Find this.
Huh?
I don't know.
Okay. Have you seen hysteroscopy being done before for postmenopausal bleeding? Yes or no?
No.
Okay. Some nod their head. Okay. Some shake their head. Okay. When you do hysteroscopy, which part of the uterus that you have to see? I mean, it's like a landmark. that you must see. You can go to the next slide on microscopy. Let's see, there's an answer there.
Ostium.
Yes, ostium. Ostium. Okay, when you do microscopy, you need to look at both ostia. Why? What's the significance of ostia? I'm not sure. Okay, basically, ostia is the junction between the uterus and the fallopian tube. Okay, so that's where the histologically the cell types are different. Okay, so as usual, just like cervical cancer, where the junction between different types of epithelium, that's the most likely part where the cancer might develop. And cervix is, and you have the transformation zone and squamocolumnar junction. Okay, at the ostia, you have what type of cells, you can read about it, that's fine, no worries. Okay, so when you do hysteroscopy, you have to look at the ostia and type of what do you call it? You look at the lining and everything like it. It should be in postmenopause. It should be atrophied. It should be whitish. It should be thin. There shouldn't be any thickened or fluffy tissue in the uterus. Okay, go on with the hysteroscopy. Tell me what you know about hysteroscopy.
Okay, so hysteroscopy can be done when, firstly, if the sampling is not feasible. Example, in patient with cervical stenosis or patient have persistent bleeding. So other than that, it can also indicated when the endometrium shows diffuse or focal increased echogenicity, and then it, from hysteroscopy we can direct visualize the uterine cavity like Dr. said before, and we can also able to visualize the polyps. So that we if and then we could also assess the structural abnormalities in order to differentiate the endometrial hyperplasia and also the carcinoma. And then if we see a focal lesion, we can take a direct biopsy from the lesion, and then we can send the sample for HP analysis. Okay.
One more point.
Mm-hmm.
The thing about hysteroscopy is it's not only diagnostic, that but you can do therapeutic as well. Okay, if you see a polyp, you can remove the polyp. Okay, and if it comes back benign, then the patient is cured. Okay, so that's the thing. If you see a large area of abnormal tissue, yes, you take biopsy first. It's almost impossible to get all the tissue out in the same setting. But if you see a singular lesion, looks like a polyp, you can treat there and then, and it's not only a diagnostic purpose but also therapeutic. Okay, just add one more line there, it can also be therapeutic. Okay,
Okay.
all right, continue.
Okay, thank you, Doctor. So the next one is cone biopsy. This is actually another form of cervical biopsy in which we remove the entire transformation zone of the cervix. So it can be done for diagnostic or therapeutic purpose for cervical CA. So it can be done in three methods, which is first one is the cold knife condensation, loop excision procedure, or we use laser. Okay, then okay.
Okay, hold on. Okay, that one is for cervical cancer, which
Mhm.
is another uh, differential diagnosis that is needs to be ruled out. But what stage of cervical cancer that is this cone biopsy suitable for? Any idea?
Mm.
Obviously the treatment will be different according to stage, isn't it? I know we are thinking more towards endometrial cancer, but since you brought it up, cervical cancer is also quite important differential diagnosis. So what do you think? If you have a guess, what do you think?
Small entries.
Stage 1, 2, 3, 4. Huh?
Stage
1A1 and 1A2.
one.
One.
Stage one
Excellent.
because it's convened to the cervix.
Okay. Yeah, when I ask you stage 1, 2, 3, 4, all you have to think about are in general terms. I mean, as a final year medical student, I don't expect you to know in detail 1A, 1B, and so on. Okay. Uh, if you can say stage 1 is confined to the cervix, stage 2 to adjacent gynae organ, okay, stage 3 to adjacent pelvic
Other
organ,
one.
stage 4 distant metastases, something like that. That is in general terms that is correct already. We don't expect a gynae oncologist level punya answer, but if you can, that would be great. Okay, so at least you'll be able to say in general, that would be good. So in cone biopsy or lip or LEDs or laser, you remove the transformation zone, including a little bit of endocervix area. What type of cervical cancer common in the endocervix rather than the ectocervix? Any idea?
Adenocarcinoma, doctor?
Apa dia tak dengar?
Adenocarcinoma?
Adenocarcinoma, yes, that's right. While ectocervix is more towards squamous cell. Okay, squamous cell carcinoma in the ectocervix, and the endocervix is the adenocarcinoma. Okay, that's fine. Continue with your next biopsy or imaging. Okay, continue.
Okay, so imaging, it is basically for to assess metastasis. First, we can do CT scan, thorax, abdomen, and pelvic, which we can see any extra pelvic disease, invasion, or any distant mass to the liver. And it is also done in preoperative staging. And then we can also do MRI in order to detect the extent of the disease, and then to detect any myometrial invasion or any cervical extension, as well as staging for the CA. And then next one, we can do chest x-ray to see if there is any lung metastasis, which we can see cannonball appearance at the x-ray and as preoperative assessment.
Okay, hold on. One question. Chest X-ray definitely you need to do because of the preoperative assessment. But if you can choose either CT scan or MRI, which one do you think will give more information for this particular patient?
MRI,
Okay, why?
because we can see the invasion of the myometrium, the uterus.
Yeah,
How
that's right. For this particular patient, we think that she doesn't have advanced disease yet. Kan, dia punya symptom apa semua were unremarkable, examination unremarkable. So MRI, if you suspect, let's say the scan is thickened endometrium, kan, and then you want to do MRI, you look for the early stage punya invasion, and it will be direct invasion for myometrium and then the alexa kan, before you go for distant mats semua. Okay, so if the patient came with ascites and jaundice, and you think she's already advanced disease, can ascites, endometrial cancer can also have ascites as well. So it used to be part of the staging, but not anymore. Okay, so if you think patient is having advanced disease, you go for CT scan, you know. And then more advanced PET scan and everything. That's all for metastasis punya mapping. Okay, that's fine. I think these three encompass the main things already. Good, well done. Okay, continue.
Doctor, I have a question. Does cystoscopy and sigmoidoscopy needed in this patient?
Okay, basically, cystoscopy is indicated if cervical cancer. For cervical cancer, you need to do EUA, cystoscopy, and possible, well, bowel involvement is a bit unlikely in cervical or uterine cancer unless patient came with symptoms. Bowel usually associated with ovarian cancer, which is very close to the bowel, and they can get stuck together and everything. But of course, that's in general. In advanced disease, all types of cancer can involve the bowel as well. And so it depends on the clinical presentation as well. So that's why it's important to take a thorough history and examination, okay, to decide what investigation to confirm your diagnosis. So on EUA for cervical cancer, you do a thorough speculum examination under anesthesia, because if without anesthesia, the patient will be in pain when you do the speculum. The cervix will be flushed with the vagina, and it's bleeding and contact bleeding. And then you look at the parametrium, and then you palpate until the pelvic side wall, because you want to find how far the cervical cancer has grown, whether it involves the parametrium and pelvic side wall. That means it's already inoperable. Okay, you cannot operate if it's already involved the pelvic side wall. So if it's only a little bit of parametrium, that's already stage 2 to B, to B. I think to A, to B, I'm not sure. But to A is the maximum you can do over time hysterectomy. To B, most people will not dare to do operation anymore. They go straight for radiotherapy. Okay, that's a little bit of cervical cancer, which is one of the important differential diagnosis. Okay.
Okay, thank you, Doctor.
All right.
So this is just additional. We should explain the complications of the procedure to the patient. Okay, thank you.
Window. Okay, Assalamualaikum warahmatullahi wabarakatuh. So I would present about the differential diagnosis of this case. So, but some of the information had been presented with the two presenters before. So, the most common cause is, the first one is atrophic vaginitis for about 60 to 80%, followed by endometrial carcinoma and also endometrial hyperplasia. So I would like to explain about the three, like atrophic vaginitis, endometrial carcinoma, and also endometrial hyperplasia. So, for endometrial carcinoma, the symptoms can be abdominal pain, urinary dysfunction, bowel disturbance, and also respiratory symptoms. It's mainly due to comprehensive symptom and also metastasis symptoms. So the patient also can present with anemic symptom due to postmenopausal bleeding and also constitutional symptoms. So for physical examinations, we can do pelvic examination, speculum examination, and also bimanual pelvic examination. So normally in pelvic examination, most of the women have normal, no finding. But during speculum examination, we can see there is a bleeding from cervical os, or for bimanual pelvic examination, we can feel the bulky uterus. So for endometrial carcinoma, so it has a high risk factor to get it, and also the protective risk for it. So for the risk factors include obesity, diabetes, nulliparity, late menopause, more than 52 years old, unopposed estrogen therapy, tamoxifen therapy, family history of colorectal, and also endometrial cancer. So for protective risk, so this patient has hysterectomy on combined oral contraceptive pills, progesterone-based contraceptive, pregnancy, and also smoking. So based on terdengar ke?
Dengar. Okay, I just want to highlight one thing. One of the most striking feature in this one is actually the bulky uterus one. Okay, when you do bimanual pelvic examination, endometrial cancer, most of the time it will not be that big. Okay, I mean, never reach 20 week size ke apa. If it's that big, you're thinking of a different uterine cancer. Any idea? Rather than endometrial cancer?
Could be uterine sarcoma.
Yes, that's right. Uterine sarcoma mimic fibroid, but it's a fast growing and horrible. And but endometrial cancer, most of the time, the uterus remains small, normal size, or maximum pun just bulky a little bit only. It never get. I would say never say never lah kan. Tapi but most of the time it's not that big. Okay. So
Okay.
that's one of the thing that you should remember lah. The rest are correct as well. Okay, continue.
Okay. So, so for informations, endometrial carcinoma have two types. So for type 1, or called as endometrial adenocarcinoma, it is the most common one. So it is estrogen driven and arise from endometrial hyperplasia. And for type 2, it is aggressive and it's carry a worse prognosis. So it is a high grade serous and clear cell histological subtypes. So for the diagnosis, I already explained by Rahil just now. So I skip. Okay. Next, we proceed to the endometrial hyperplasia. So for endometrial hyperplasia, is most often is caused by excess estrogen without progesterone. So if ovulation does not occur, so progesterone is not made, thus the lining is not shed. So the endometrium may continue to grow in response to estrogen, thus it can cause hyperplasia. So why endometrial hyperplasia occur? So first one is menopause, perimenopause, and the use of medication like estrogen. So if the patient had irregular menstrual period, especially in polycystic ovary syndromes, and also obesity. Okay, for the risk factor of endometrial hyperplasia, so first one is age is older than 35 years old, white race, nulliparous, late menopause, and early menarche. And this patient having certain condition like diabetes mellitus, PCOS, gallbladder disease or thyroid disease, obesity, cigarette smoking, and also family history of ovarian, colon, or uterine cancer. Okay, for endometrial hyperplasia, it have four types. So the first one is simple, second complex, the third one simple atypical hyperplasia, and the fourth one is complex atypical hyperplasia. So for the complex atypical hyperplasia, patient will has high risk to get endometrial carcinoma or malignancy later in life. Thus, the treatment offered is hysterectomy. So for the symptoms of the endometrial hyperplasia, it can be heavy menstrual bleeding or postmenopausal bleeding. Okay. So for the treatment of endometrial hyperplasia, we can give progestin either in forms of oral, intrauterine device or vaginal cream. Okay. The last one is about atrophic vaginitis. So atrophic vaginitis is due to estrogen deficiency. So it will cause thinning, drying, and inflammations of the vagina. So it mostly occur in postmenopausal women. So the symptoms can be vaginal dryness, burning, pruritus, abdominal discharge, dyspareunia, chronic dysuria, and also urinary tract infection symptoms. So for physical examination, first we can see there is an atrophy of the labia major and minor with loss of subcutaneous fats. So second one, we can see along with the dry labia, vulvar lesion, and also we can see sparse pubic hair. And the third one, we can see vaginal epithelium may appear pale, smooth, dry, and fiber with loss of bouquet. And there is area of inflammation with patchy erythema and petechiae may be noted. Okay, for the treatment of atrophic vaginitis, we can give estrogen replacement therapy, which is either systemic estrogens or transvaginal delivery of estrogen, like estrogen in the form of creams, pessaries, or hormone-releasing ring, like estring. And also we can add on moisturizer and also lubricants. Okay.
Okay.
That's all.
Okay. Next question. Any question from the audience so far? What do you think? Any you want to ask or you want to share?
Doctor,
What
Betul.
okay. Doctor,
Aku
I have a question regarding liquid-based Pap smear. Meaning that the 5 yearly interval from the beginning, if it already negative, we straight away go to 5 years. There's no need like conventional with 1 yearly for the first 3 years, 3 yearly. But for the liquid base, we straight away go to 5. Is it like that, Doctor?
yang 5-year interval tu kalau buat HPV testing, okay, dia ada juga liquid based cytology yang buat without the HPV testing. That one continue macam yang current screening program lah. If you have HPV testing and it's come out negative, that's when you can space it out to 5 yearly. Okay, liquid based cytology has better advantage compared to using spatula, pap smear kan, sebab dia dia remove a lot more cells and it reduce artifact sebab liquid base tu they able to centrifuge and just get more cell yang better quality lah untuk untuk dia buat cytology tu. So kalau HPV negatif baru jadi 5 tahun sekali tu. Okay. Tadi ada someone nak tanya soalan Dahiyah ke?
Yes, Doctor. Actually, I'm not sure I should ask now, but I just want to confirm my understanding based on the grading of the endometrial CA. We apply the grading of high grade or low grade to the type 2 endometrial CA, because from my understanding, once it is type 2, it's considered high grade. Is it?
Okay, itu soalan untuk gynecologist. Saya sendiri pun tak berapa pakar lagi lah untuk menjawab soalan tu. So I don't want to give you ajaran sesat lah. Yeah. So mengaku yang saya pun tak tahu jawapan. So better sama ada baca balik buku gyneonco ataupun postgrad ataupun tanya yang berkaitan lah Prof. Mokhtar, Dr. Muzamil, Dr. Ali. Pilih je yang mana you nak.
Okay, thank you, Doctor.
Sorry, Dr. Huda, Dr. Adibah pun boleh tolong juga. Dia pandai juga. Contohlah. Okay. So yang I tahu grading is important for prognostic purposes as well as choosing the further treatment like chemotherapy apa semua kan. That's all I know, but for specific type tu I'm not sure. What I know is endometrioid has better prognosis, has better survival rate compared to type 2 punya lah. Yang type 2 tu more aggressive and poorer 5-year survival. So that's all I know as a general gynecologist lah. So if you want to know further detail, need to go to a subspecialty punya advice. Okay, continue
Doctor,
dulu.
can
Ada
I
soalan?
ask question? For the bulky uterus, is it possible
Yeah.
to be palpable upon by manual examination?
For which one?
Bulky uterus.
Bulky uterus. Most of the time, it's only just palpable. 14 weeks, 12 weeks, okay? So it's not that obvious. Unless it's already advanced pun, I've never seen endometrial cancer reaching umbilicus level. So most of the time, it's barely palpable in the suprapubic area, and you won't be penalized if you couldn't feel it, so because the endometrium only is inside the uterus, if it doesn't involve the myometrium and everything, the uterus size will not be enlarged significantly, and endometrium saja they confine dalam uterus lah selalunya for stage 1A ke apa kan. Kalau advanced stage maybe, but I've never seen one that big lah. Okay.
Doctor, because one of case note I seen that it say that the uterus is palpable at 6 weeks through by manual examination. So is it really possible?
If you ask me, I is never apa tu, you can never tell. By manual examination, 6 weeks, 8 weeks, 10 weeks, you cannot tell. Okay. I've never read any book describing what a 6-week size by manually, what's a 8-week size or 10-week size. The only time when it's palpable and all textbook agree on it is 14 weeks. 14 weeks is you're able to feel it just above the symphysis pubis. Okay, 12 weeks barely if you can get deep in below the symphysis pubis. So itulah yang below 12 weeks and everything, they just say bulky but they cannot quantify the how many weeks. Okay, so if you want, you can question the person who did the examination, but he or she will be able to give a right answer lah. Prof Hamizah will just laugh and scold them. Okay, sorry. Okay, continue. Let's continue with the presentation. Okay.
Regarding the endometrial thickening, the cut-off point is 4 mm, but in RCAG guideline, it is said that if patient on specialty or pregnancy cell, the cut-off point will be higher. So how much higher?
Okay. Basically, there are still debate on the cutoff point for suspecting endometrial cancer. Level of 3 millimeter, 4 millimeter, and 5 millimeter. Apa tu, the most commonly quoted level in research punya studies. Okay. However, most guidelines choose 4 millimeters as their cutoff point because it give a nice 10% risk of endometrial cancer if it's more than 4 millimeter lah. That's like a nice rounded number and they easy to quote and everything. So and it's significant enough to warrant further investigation, okay, to rule out endometrial cancer lah. So kalau apa you tanya tadi apa, kalau premenopause dia even thicker Is that
It's
your question?
question on HRT or tamoxifen.
Yep. Yep. HRT and tamoxifen, of course, you're gonna have estrogen effect. Tamoxifen, although is actually selective estrogen receptor modulator, and it has negative effect on the breast cells, but tamoxifen actually has positive effect on the endometrial cell. It's estrogen rather than anti-estrogen effect. Okay, so they're going to have thicker endometrium thickness due to the extra estrogen effect. So difficult to say. I would say 4 millimeter is the most quoted in research and guidelines. So use that as your cutoff point. So you won't go wrong lah. Okay.
Doktor nak tanya.
Yep.
Kalau TA pun dia takkan change the shape of the uterus
Macam mana?
Macam shape of the uterus, is there any significant changes juga in endometrial CA?
Itulah. I mean, like I said earlier, endometrial CA usually confined inside the endometrial cavity, usually. But of course, 1B, they dah invade more than 50%. Once it's involved the myometrium and everything, it can become misshapen. So, the one that I've seen before, although I haven't seen a lot lah as compared to the gynecologist kan, tapi yang biasa I tengok shape dia lebih kurang sama je, macam normal size uterus, normal shape uterus, but when you cut open the uterus tu baru nampak dia punya gross pathology dia invade sampai banyak mana. Kebanyakan surgeon dia suka untuk cut open the uterus immediately after operation so that they can see terus agak-agak berapa persen involved kan. Kalau more than 50%, they tend to go for pelvic node dissection because of higher risk. Tapi latest research kata buat ke tak buat pelvic node dissection, it doesn't change much in terms of prognosis semua lah. So macam management dia still the same, you go on chemotherapy apa semua kan. Kalau buat pelvic lymph node ada dia punya complication pula, jadi lymphoma pula, apa tu, I mean lymphedema where the lymph punya fluid apa semua accumulate kan in the legs apa semua. We've seen some in HTA before. Okay, continue with the next question.
Okay, so we continue our scenario. So, her investigations suggestive of stage 3 endometrial carcinoma. What are her treatment options? So, this is the staging for endometrial cancer by Figo staging. So, we look at the diagram, so it is easier for us to stage the endometrial cancer. So, for the stage 1, it is confined to the uterus only, which is stage A. It is only less than 50% of myometrial invasion. For the stage 1B, it is more than 50% of myometrial invasion. Okay, for the stage 2, there are invasion to the stomen of the cervix, stomen, and then for the stage 3, so either the tumor invade the adnexa or it invade the invade the parametrium or the vagina, or for the 3C, it involve the pelvic nodes. Okay, so for the stage 4, the tumor already invade the bladder or bowel, and then for the stage 4B, it already went to the abdomen or inguinal lymph nodes. So at least we know for the stage 1, 2, 3, and 4, it's okay for us, I think, not for ABC. Okay. So next, since patient has stage 3, okay, so this is the treatment options for the surgical. So stage 1 and 2, it is considered as the early disease of the endometrial cancer. So the gold standard of the treatment is surgical, which is stepso,
total abdominal hysterectomy, bilateral salpingo-oopectomy. Okay, and then plus minor lymphadenectomy as Dr. said just now for the pelvic lymph removal. Okay, and then for this patient got stage 3 of endometrial cancer. Therefore, stage 3 and 4 it is considered as the late disease. So what we can do is we can do a debulking surgery. So debulking surgery, we does not aim to eradicate the tumor, but we just for the removal of the tumor as much as possible that we can, so that we are hoping that post-operative radiotherapy can kill the rest of the tumor. Okay, this is we do a debulking surgery for patient who is fit for surgery only. Okay, if patient is unfit for surgery, we go for radiation therapy. Okay, if there is a distant match, then the patient might be considered a palliative surgery. Okay, so this is a post-operative radiotherapy. So why we do the radiotherapy post-operatively? It is to reduce a local recurrence rate of the tumor. And then we might consider a chemotherapy for patient who had a metastatic disease. So this patient, we need to assess if patient is fit for surgery first, and then we can do a debulking surgery. And then post-operative radiotherapy plus minus chemotherapy if there is any metastatic disease. And then this is the general prognosis that I take from the 10 teachers according to stage of the endometrial cancer. Eventually, prognostication of the patient, it depends on the staging, the types of the tumor, and also the grading, histopathological grading of the tumor itself. So this is only the general prognosis for patient in endometrial cancer that is for 5 years survival only. Okay, so for example, in stage 1, it might be said that the patient had a prognosis of like 88%. However, it depends, is it low grade or high grade? So, high grade of stage 1 might be a lower prognosis compared to the low grade stage 2. Okay. So, it depends on the individual basis. Okay. And then for this patient, so patient got stage 3. So for the general prognostication for this patient, according to the stage, which is the prognosis is about 55%. Okay. I think that's all for my part.
Okay, question. This table here, 5 year survival, how do you want to explain to the patient?
Okay.
Counseling. Contoh
So
counseling to patient.
counselling untuk stage 3 ni, we will counsel patient. Kita akan buat semampu mungkin, tapi macam dia punya recovery, dia punya cure rate tu macam untuk hidup dalam masa 5 tahun tu kita nak kata macam 50-50. So macam mana?
Itulah soalan ni nak tengok kefahaman you tentang the statistik. Adakah maksud dia ada 50-50 chance untuk masih hidup 5 tahun lagi, ataupun adakah 55% badan dia akan rosak? What does it mean by 55% tu?
50% tu adalah percentage untuk patient dapat survive dalam masa sampai 5 tahun akan datang. Yang tu yang saya faham lah, doktor.
Yang sebenarnya it's bayangkan kita ada 100 orang dalam stage 3 kan, yang dah follow up for 5 years, 55 orang masih hidup, 45 dah meninggal. So that's how the statistic was derived from. So it doesn't really say for this particular patient she has 55% chance of still alive in 5 years time. Kita selalu dengar dalam TV lah, dalam movie lah, apa semua kan, doktor kata you ada 6 bulan je lagi untuk hidup apa kan. In real life, I've never find any doctor yang berani cakap macam tu kan. Ini semua kuasa Allah kan. Okay, I've seen one patient before had really bad COPD, chronic obstructive pulmonary disease, bad smoker apa semua. Dia punya ABG dia pH dah 6.9, dia punya bibir dah cyanosis kan. But medically speaking, dia kata probably akan mati tak lama lagi kan. Dah high on oxygen semua pun still SpO2 low around 60 to 70% kan. But we still unable to say bila dia akan mati. Mana? Okay. It happened apa tu, the doctor yang tu saya ingat dia cakap, oh maybe in the next 24-48 hours kan, dia teka je lah kan, dia teka. Dia punya apa, saudara mara apa semua datang kan, sekali dah ada 3-4 hari masih belum meninggal, ada yang berani tanya doktor bila dia nak mati dia. I mean this is not in Malaysia lah kan, dekat tempat lain kan. Tapi itulah, I wouldn't guess bila patient akan mati dah. Itu semua tu dramatization from movies je lah, jangan percaya. Okay, alright, continue. Ada lagi soalan? Your slide ni apa lagi? Yang bawah-bawah tu apa?
Ada tu just punya Jalkini punya part haji.
Alright.
Okay. Thank you, Ani. I'll be presenting my part. Can everyone see my slide? Okay.
Okay, before the slide come out, tadi nampak slide tadi kan, dia dekat Arab Saudi, lepas tu dia buat general apa history dengan examination je, tak ambil investigation pun, and then dia suruh balik Malaysia jumpa gynecologist. What do you think? Okay ke tak management macam tu? Macam doktor buat kerja sekat jalan je, okay ke tak?
Tak
What do you think? Tak okay. Kenapa tak okay?
Should explore more and give a more thorough referral.
Any other opinion?
Doktor kalau nak buat, if we do investigation there, so it will be more costly kot doktor, I think. Because of the charge. The foreigner maybe. Maybe need to refer to Malaysia to further investigate.
Betul. Because it's not a life-threatening there and then emergency punya treatment kan. All the thing that can wait apa semua, tunggu dia balik Malaysia lah untuk proceed. Bayangkan you macam kerja klinik ni dalam medical relief station je, selalunya bawah kemah je kan. Ada stetoskop, ada faham tak? Mesin scan pun tak ada. Faham tak? Ni apa, senario real life ni. So kita ada kawan apa UIA yang pergi join the tabung haji punya group kan as medical ni. Do you know that doctor can go haji earlier if you join the tabung haji group tu? So you don't have to wait 70 tahun. Faham tak? So that's one way lah kalau you nak pergi haji awal kan, join the medical relief team. Apa tu? Cara yang dia buat tu betul lah, tapi kena advise betul-betul lah that apa tu, the investigation apa semua belum complete lagi, lebih baik settlekan bila balik Malaysia nanti kan. Bagi dia surat referral terus, dia pergilah dekat mana yang paling terdekat, yang paling mudah. Okay, sambung Jasmine, you punya slide tak keluar lah, dia keluar. Mungkin you belum buka. Okay, alright, you share the whole screen kan. Okay.
Okay, can you hear me? Alright. Is it clear? Everyone see? Full status. Okay. Right. So I'll be explaining about Hajj status in this case. So what is the question that we face currently? So in our case, this patient, if the bleeding happens during Mina was significant in amount and patient needs to be hospitalized and transfused, what is her Hajj status? So when we talk about this, so mainly the issue that we face right now is that we have a case of abnormal uterine bleed. So with this abnormal uterine bleed, the term that we use here is istihadah. Okay, so I'll explain more about that term. But before I proceed, regarding the question, the Hajj status is still sah. She can complete all of the rukun of Hajj, of which I will explain later what are the rukun of the Hajj. And in a case, maybe not in this case, since patient is already menopause, but in certain case whereby the patient have a period, she can complete all of the rukun except for the tawaf and sa'i. And there is a very explicit, there's a very specific hadith that address this issue. And for this case, basically we have a woman who have istihadah, and for our case, the woman is considered clean from period or nifas. Okay, so this is the thing that we have to take into account. So firstly, how do we differentiate istihadah or abnormal uterine bleed with darah head, which is period? So as you can see, this is a general way of differentiating. So period, they tend to be more black in nature, associated with yellowish discoloration, and it's smelly and fishy odor probably. It's more concentrated, but then it is a normal physiological bleeding. Unlike abnormal uterine bleed, it's something that's physiological, it's something that is regular in most of the patient, and it is not pathological. So it comes out from the uterine. But however, in case of abnormal uterine bleed, the difference is that it tends to be more less clear, keruh, and then it's doesn't smell like period. Okay, so I'm not sure how to explain that, but it does not smell like period lah. It's a bit it's a bit more clear in consistency. It's not as concentrated as a period, and it's a pathological. Okay, so as you can see here, you can see the color. So if it's abnormal uterine bleed, roughly it's more clearer in nature, unlike period. Okay, so we take it, we make it more specified and more more specified to differentiate the differences between abnormal uterine bleed and period. So what we see here, the 4 criteria mainly is what we can say character of period, whereby usually if there's a heavy bleed, it will not prolong more than 15 days. And if there's a weak bleeding, it would not be more than 15 days. So the maximum number of days that one could get that menstrual bleed is supposed to be within 15 days. Anything that is more than that is you can consider it as a form of abnormal uterine bleed or istihadah. Okay, so as mentioned here, sekiranya salah satu daripada syarat ini tidak dipenuhi, maka hendaklah mengikut adat kebiasaannya, which basically means if any of these criteria of a period, typical period, is not fulfilled, we can consider it as istihadah of abnormal uterine bleed. And as we established earlier, abnormal uterine bleed is considered as something clean. We can perform all the, we can complete all the Hajj, etc. So we refer to this hadith. So Rasulullah bersabda kan, jika darah haid ia berwarna hitam seperti diketahui banyak kaum perempuan, jika yang keluar adalah darah seperti itu, tinggalkanlah salat. So basically, if you have period, you abstain yourself from prayer. Jika yang keluar adalah darah lain, so if it's anything else than period and it's per vaginal bleed, so basically it's abnormal uterine bleed, yakni adalah darah istihadah, berwuduklah setelah mandi dan laksanakan salat kerana darah tersebut adalah penyakit. So it's a pathological It's a pathological bleed, so you can still pray as per usual. So another hadith I would like to elaborate. So isi ini berdasarkan hadis daripada Aisyah radhiyallahu anha. Katanya Fatimah bin Abu Baish menemui Rasulullah SAW dan bertanya, maksudnya, wahai Rasulullah, aku perempuan yang didatangi darah istihadah dan masih belum bersuci. Adakah aku perlu meninggalkan solat? Jawab baginda, tidak perlu, kerana darah itu adalah darah penyakit, bukannya darah haid. Okay, as mentioned previously. This similar hadith, it says, daripada Fatimah binti Abu Baish, dia kedatangan darah istihadah, lantas Rasulullah SAW bersabda, maksudnya jika darah haid, ia adalah darah yang dikenali kehitam-hitaman. The nature of it, of the bleed is blackish. Jika ia bersifat demikian, janganlah bersolat. Dan jika sebaliknya, maka berwuduklah dan dirikanlah solat. Kerana darah itu adalah darah daripada urat, which is darah penyakit pathological. So we can proceed as per usual. So we don't treat it as period. Another hadith, maka focus on the point whereby it says here, maka tunaikanlah apa sahaja yang biasa yang dikerjakan oleh seseorang yang mengerjakan haji kecuali tawaf di Baitillah sehingga kamu suci. So in this case, in a case whereby the woman is have a period during the Hajj, in this case there are some rukun, some acts of Hajj that you could not do. Unlike the case of istihadah where you are considered as clean, you are not allowed to do tawaf di Baitillah sehingga kamu suci. So this is something important, and it helps us to further educate the patient, our patient here, to understand the situation, because if she might be okay or well, she might disseminate this information to her daughter ke ataupun auntie or mother. Okay, so we put in a hypothetical situation whereby because we already clear cut for our case here, the patient can complete her Hajj with no issues because she is considered as clean. But in a case whereby we have a patient who had period during the Arafah day during Hajj, there are two cases. In the first case, whereby the condition is favorable, you have enough time, the flight is still long, your other jemaah are willing to wait for you for the to clean yourself. So in that conducive environment, you should perform ghusl once you know you get period, and then you can complete your tawaf and sa'i. So however, in unfavorable condition, your jemaah wants to go back early ke, nak pergi shopping ke apa, or they want to, your flight ticket is few minutes, they make it advance ke, macam Asia ke apa kan. So in this case, you need to pay a dam in the form of camel. This is one is based on mazhab Hanafi. Because what you do here, you do not complete the rukun of Hajj. Okay, so I'll explain. So there's two things that we need to make it clear, is that there are, one is rukun, there's a wajib haji, six things which make haji is wajib. Another is about rukun. So what's the difference, and how which one is, how do we address these two items? So in wajib punya haji, wajib six perkara, you have to do niat ihram di miqat, bermalam di Muzdalifah, melontar jumrah Aqabah, bermalam di Mina, melontar ketiga-tiga jumrah, dan meninggalkan perkara-perkara larangan semasa dalam ihram. So all this stuff, all these items, we need to fulfill. If we were unable to fulfill it, we have to pay our dam, membayar. So we have an alternative. So if we did not complete and we pay, so our Hajj is considered sah. However, in rukun of haji, which is different to items that is wajib for haji, which are six: niat, wukuf, tawaf haji, sa'i, bercukur, tertib. These items is mandatory. So all of these must be completed. If any of this is not completed, it is not considered, the hajj is not considered as sah. So this is important thing that we need to explain to our patient here today. So in our case, the patient too it falls under this category, bermalam di Mina. So in the case, but because in our case, patient is only istihadah, so it does not affect lah. So the patient should not does not need to pay the dam because she is not on period and she is considered as clean. However, if she has period and she can't do the tawaf and hajj, she have to address in a way I've mentioned previously. Okay, is everyone clear? Okay, so this is an example of jamrah lah. Okay, so people are throwing pebbles semua. This is
Just me, hold on. Okay. Go back to your slide previously. Okay. That's good. I really like your explanation, very clear and very concise as well. So she's in Mina and then she started to bleed. The other scenario is if she bleeds a lot and needs to be admitted and being transfused and everything, and beyond 13 Zulhijjah. Okay, let's say she has to be in the hospital for 1 week, for example. Kan? So what will happen to her Hajj?
okay.
Like you say, wajib haji tu boleh ganti dengan dam. Okay, itu jawapan pertama you tadi. What about yang rukun lain? Ada rukun yang dia belum siap lagi ke kalau?
Okay, in this case, actually I'm not so sure because tak pernah buat haji lagi. So I'm not sure by being in the hospital for over 1 week, whether you will miss sa'i or bercukur tu, I'm not quite sure because the chronology is quite important in this case. So I'm not that sure. But the principle is that if we cannot miss any of the rukun, and the hajj for the wajib, we need to replace with dam if we do not manage to complete.
Doa, you wanted to say something?
Yeah, I'm not sure if this would be like a different belief than the rest, but for us, Hajj is Arafah. So as long as she has completed Arafah, her Hajj stands, and she can try to complete the rest after 13th Dhul Hijjah. But as long as she has completed Arafah, then she's good. That's what we do lah. How we think about it.
That's right. The rukun wukuf is in Arafah, which she has done on the day when it should be. And then the Mina part is only a wajib haji, which can be substituted with the dam according to her condition. Okay, yep, you're right. But tawaf haji and sa'i, is there a time period where you need to perform it? That's the soalan cepu mas. Any idea? Can you do tawaf and sa'i after she being discharged from hospital and she paid dam for the wajib haji that she did not perform? And is it possible?
If I were to base on the case scenario that was asked in one of the portal regarding the ask mufti regarding the case, they say like in a case of a patient in a period and conditions favorable, she can do usul and complete the tawaf and sa'i that she missed during that time period. So in that case, putting it in this situation, I assume yes, can. Once she have been well and discharged, she can replace the tawaf and tawaf haji and sa'i at her own convenient time.
Betul. Yes, you're right. So you can use the same analogy. But what about her ihram? When is she considered complete ihram? Based on your rukun haji perkara tu kan. So ihram is from niat until perempuan senang sekali lah, lelaki susah. Lelaki pakai towel je kan. Perempuan masih boleh pakai telekung. Ini dia.
I'm not sure.
Siapa pernah pergi umrah? Dia punya masa ihram dia similar to umrah. From niat until kalau teka dia kalau teka
niat until tawaf wada something ya.
Sampai bercukur je.
Cukur.
Tahallul dia balik.
Tahallul.
Okay. Sampai bercukur tu kira dah lega lah, selesai daripada ihram tu. So dah boleh tukar pakai baju biasa apa semua. Tawaf wida tu dah nak balik dah ke Malaysia apa semua. So it's like your final time you're in Masjidil Haram. You can wear your own clothes apa semua. Kebanyakan orang masih pakai jubah apa semua lah. So tak ada pakai kemeja dan seluar ke apa, tak ada. You jadi janggal sangat lah kalau pakai kemeja dan seluar dalam Masjidil Haram. Semua orang pakai jubah, pakai telekung kan. Itulah. Okay. Saya sendiri pun belum pernah pergi haji lagi. Kalau daftar haji lagi 70 tahun baru dapat pergi, umur 113. So itulah, we all need to find ways to mempercepatkan giliran. Okay, make sure we all dah daftar tu satu. Lepas tu kumpul duit. At the moment you need about 10k untuk layak untuk pergi haji. Go to the kursus and lepas dah siap kursus apa semua, you can start rayuan. Maknanya rayuan semuanya dah ada kan, dah ready. So rayu boleh tak nak join. So dia masuk macam waiting list rayuan lah. Other ways you can go to swasta punya. Swasta pun ada some quota juga kan. And another way is join other country punya quota, like pergi UK belajar, lepas tu daripada UK join the quota UK kan. Kawan saya pernah buat macam tu. Tapi you have to be full time student semua lah. Adalah syarat-syarat dia kan. Kena at least belajar 20 hours per week, baru diiktiraf sebagai full time student. So baru you boleh guna kuota negara tu. Faham tak? Something like that. Dan yang saya mention tadi kan, medical relief team kan, while dekat sana apa semua, you boleh buat kerja medical relief team while you performing your haji as well. So that's another possible way lah, insyaAllah. Okay, take home message. Medical take home message dulu. Apa yang take home message? Bagi 2-3 ayat yang penting untuk diingat malam ni. Pukul 11.
Me dah kan?
Untuk yang medical part dulu ya, rather than the haji part.
Okay. Regarding medical part, the take home message, so it's important to know the differentials and how to approach post-menstrual bleed. And then it's important that we know how to differentiate the different types of cancers, the endometrial, ovarian, and the ovarian, endometrial, cervical cancer, because these pathologies are different in presentation and findings.
Okay, and one more thing is slightly different way of saying what you just said is postmenopausal bleeding is a red flag. Okay, it's a endometrial cancer until proven otherwise. Okay, you need to rule out before you can say it's atrophic vaginitis apa semua. Okay. So endometrial cancer is the most important one. Postcoital bleeding is red flag for cervical cancer. Okay. Similar lah, you need to rule out proven otherwise kan, anti proven otherwise. Macam tu lah. Okay, postmenopausal bleeding, kalau dekat UK, dia ada fast track. Fast track. Within 2 weeks, dah kena apa tu, has been seen, diagnostic has been done, awaiting result dia, faham tak? Within 2 weeks. So, kita punya appointment system apa semua kan, kita kena fast track kan patient ni. Yang mana ada postmenopausal bleeding, see within the same week ke better, so that dia kita dapat buat Pipelle ke kalau ni kan, ataupun arrange for hysteroscopy pun boleh juga kan. So, itulah, it's a fast track punya investigation. Okay. Alright. So, with regard to haji, let's all pray and doa so that apa tu, all of us dijemput oleh Allah kan untuk mengerjakan haji, lengkapkan rukun iman, rukun Islam rukun Islam yang kelima, dan insyaAllah lah doakan banyak-banyak semua orang. Okay, cukuplah kot ya. Thank you very much everyone for your cooperation. Inshallah, I will upload the video of tonight's session onto my YouTube lah kot, probably, so that you can watch it again. I think maybe because you have seen the previous punya group kot. Okay, yeah, start recording dulu. Okay, I dah stop recording. Maybe because you have seen other